Good morning, everybody. Welcome to the webinar for the Research Coordination Network. We're going to wait for another minute or so while people trickle in, and then we'll start. Okay, we're going to start with just a few announcements. So this slide shows today's speakers, Nathan LaCross from Utah Department of Health and Human Services, and Rebecca Schneider from Houston Health Department. And we're really excited to hear from them about how wastewater surveillance is actually being implemented in these very early adopter locations in the West. And next month, we also have two great speakers. Scott Meschke is going to talk about global perspectives on the surveillance of poliovirus in wastewater, and Edwin O from University of Nevada is going to talk about ARGs in wastewater and application to public health decision making. If you have a speaker that you're interested in hearing from, scan this QR code and you can nominate them. And we have one more announcement before we start.
I'm sure a lot of you have seen this email, but if not, RCN is also hosting another workshop this month. It's on April 20th from noon to 2:30 p.m. Eastern time. And the goal of this workshop is to talk about bacterial monitoring in wastewater, because there are some differences with viruses and a lot of us are transitioning. We have 3 panelists, and just like with the nomination form, you can scan this QR code to register. We do ask that you only register if you're able to attend for the entire 2.5-hour period, because we want the breakout room discussions to be fruitful. And if people are popping in and out, that can be a little bit more difficult, but hoping to see a lot of you at the workshop.
Okay, with that, we're going to pass it off to our first speaker, Nathan LaCross. And while he's sharing his screen, I want to remind all of you to put questions in the Q&A, and we'll have a moderator who will moderate those questions. Thanks, Nathan, for joining us.
Thank you for having me. Pleasure to be here. So, as I said, I'm Nathan LaCross. I manage the wastewater surveillance program for the Utah Department of Health and Human Services. I'll talk a bit about our program today. So, a bit of background. As was mentioned, we were a fairly early adopter of wastewater surveillance for the COVID pandemic, largely as a result of really a fortunate combination of circumstances and expertise and a associate state agency looking for some way to help out with the pandemic response. And so we actually got started planning of this began in February or March of 2020. This predates my involvement a little bit, so I'm a little bit fuzzier on those particular dates, but certainly sampling began by April of that same year. And this was a fairly small, in comparative terms, pilot project. Just 10 sites across the state. It's about 40% of our state's population, because our state's population is highly centralized along what's known as the Wasatch Front, this north-south running mountain range from about Logan in the north to Provo down in the south, Salt Lake City right about in the middle of that. And at that time, we were collecting 1 sample per week because, unsurprisingly, we had no idea what was going to be best. We certainly hadn't done this before, and there was relatively little work in this area at this sort of scale. And there were 3 academic laboratory partners that are actually doing the lab analysis and the samples that were being collected. This is University of Utah, Utah State University, Brigham Young University. Unsurprisingly, quite a bit of time early on was spent in making sure that the methods were as consistent as possible between all these universities, because they are very widely separated, very entirely different people doing those analyses. And there's already a lot of variability you can find in the data. You want to minimize all sources that you possibly can. This proved to be quite successful. Got good data fairly quickly, and it was pretty easy to imagine some good uses for it. And so we were able to secure some funding to expand this. And by the late summer of 2020, we'd expanded out to about 46 sites across the state, which is about 90% of our state's population. Not too many more places to actually have started sampling at that point, because we do have, of course, some relatively small in Utah, but still some fraction of our population on septic. And this is around the time that CDC's National Wastewater Surveillance System, or NEWS, NWSS, started, and we were one of the first 8 partners within that. Currently, this is what we're doing. So we have dropped a number of sites that we're sampling. We did this back at the beginning of 2021 because we changed from sampling once per week to twice per week. And with that, it's about double amount of work, about double the amount of money as well. And so it's a combination of, we couldn't afford at that moment to keep all 46. And to be very frank, a lot of the partners, especially in the more rural areas where you can see some pretty big gaps in the map of where we're currently sampling, especially central Utah, very rural, very sparsely populated. So very small wastewater treatment facilities. A lot of them told us they just couldn't give us samples with that frequency, even twice per week. Even once per week for some of them was kind of pushing it, because they may have one part-time person who's there a day, maybe 2 days per week. So we've dropped down to 34 facilities, but sampling twice per week. And we felt that additional sampling frequency, the additional granularity you get with the data was a good exchange in that case. And that's going to hopefully soon be 36. We're onboarding a couple of new sites. And this still does cover about 88%, we're estimating, percent of the state's population, even though we dropped, close to a dozen sites, because most of them were very, very small. And so it is an unfortunate aspect. We do have considerably less coverage, and so less awareness of what's happening in these more sparsely populated rural areas. But there's a lot of complications that go into sampling there. As mentioned, sampling twice per week, and we did move all of the lab analyses from those academic partner labs to the State Public Health Lab in August of 2021. Largely because our academic partners were really looking to go back to their normal research work. They weren't particularly interested in being a more or less permanent part of a state surveillance system, which is totally understandable. They provided truly excellent work. We're currently doing qPCR assay for both N1 and N2. We put them on the same fluorescence channel, but we are going to be moving to droplet digital PCR very soon, which would be both exciting and useful and really complicate the interpretation of our data for some period of time. This is the type of data we're getting. This is just an example for one particular site. We tend to show on various dashboards or analyses about a year's worth of data, just because as you expand out the time frame, it just gets increasingly complicated to interpret and a little bit unmanageable. So on the top there is just our wastewater surveillance data. We do normalize the data we get from the lab by both estimated population and the flow during the sampling period, which we think is a fairly important thing to do. The estimated population, of course, doesn't change from sample to sample. The population we're actually sampling will be doing that, because we're actually capturing not just resident population, but anybody who is moving through the area or traveled to the area and is using the bathroom, essentially. But you can't really get accurate estimates and that sort of thing very easily. The flow during the sampling period does change, and that does help to account for things like increased or decreased use, as well as, which is very pertinent right now, runoff and infiltration of groundwater. We have an amazing amount of snow in Utah, just like California does, and it's all starting to melt quite rapidly. So we're seeing considerably higher flows than average. And then the bottom in the blue there, that is the daily case rate per 100,000 for that same sewer shed. We geocode all of our cases by sewer shed and a number of other geographies. And then you just calculate the case rate based on the cases that have been allocated to that particular sewer shed. As mentioned, the data kind of gets a little bit more unmanageable. You can certainly display more. This is almost all. There's a little bit of data, a little bit back further for this particular site, because it was one of those first 10 in that pilot project, but the labs are still kind of figuring out proper methods, and the data is a little sketchy back then. But to my mind and to my eye, it gets a little bit harder. It gets considerably harder to interpret, actually, as you go further back. So this is just more data, but it doesn't make it easier to look at, to my mind. Couple of ways that we analyze the data. Trend is it's not overly complicated by any stretch mathematically, but it is the more complicated of the two. But it was also the first one we kind of decided on a method for. I think it was that aspect of things was considerably easier. And we're using essentially an adaptation of a method that CDC ended up using for their own analytical purposes. And this is just linear regression on log transformed normalized values. So you just put all the wastewater data onto the log scale, do linear regression on it, and take the trend. We're currently using a 13-day period. This will normally be 4 samples since we sample twice per week. Decided on this, CDC uses this combined 8-day and 15-day period. Those will be 3 samples and 5 samples respectively. We may end up switching to that. I was hoping to kind of find something, sort of the Goldilocks situation, something in the middle that worked essentially as well as the two. It seemed like that was going to be the case initially. Now I'm starting to think that maybe that something more like that combined period may actually perform a little bit better. But the 13-day period still does work fairly well. The major difference is in the p-values. So CDC uses a p-value of 0.05, so bog standard thing. Though entirely arbitrary, of course. We use something that is considerably more lenient, perhaps a little bit too lenient. Is a p-value of 0.3, and this is in no small part because the wastewater data is, you see a lot of volatility and a lot of variability in the data. And if you look at the results you get especially over time, using a lower p-value, the more standard, although again, entirely arbitrary, 0.05, you'll find that it doesn't really do a whole lot. You rarely will find a significant trend. I may have kind of overcorrected, so we may be dropping that down, but I would doubt more than say 0.2, maybe 0.25 is even more likely than that. And so you can see an example on that map. The shape, as we're currently displaying it there, is related to the trend. Downward pointing triangles are significant decreasing trends. Upward pointing triangles, of which there is, I think, just the one there, is significant increasing trend. Circles are either can't find a trend or it's just actually a flat line. It's plateau or indeterminate there. And then there aren't examples of that X where there's just not insufficient data, because you need at least 3 samples within that period to be able to calculate a trend, because 2 points, you're doing linear regression, that's just as a perfect fit, and you're not going to get anything from that. But there isn't an example of that on this particular map. This is the part that was, mathematically speaking, certainly easier, but conceptually, and trying to figure out a reasonable method for doing this, we found to be considerably more complicated. So, and that's figuring out some way to analyze and compare and aggregate on concentration or level. So the main issues revolve around the fact that every site is unique, and thus the data and any thresholds you generate from the data aren't, in my opinion, really comparable and applicable between them. To my mind, it's not certainly not a particularly good idea, and it's not probably very valid to directly compare data between 2 different sites, because there's so much that we don't know that differs between the sites and will have a significant impact on the data we're generating from said sites. Now, this is not a universally held opinion, and I may well be proven wrong in the future, but that's my current thoughts on that. But there's still, of course, a need to compare the data and the sites, or data between sites, excuse me, and determine what a given data point or set means. And you often want to do aggregation, so like maybe to the county level, the local health department level, or to the entire state level. And so you need some probably relative measure of concentration, which is what we ended up doing. So our ultimate solution, more or less, was to calculate site-specific quantile thresholds at what are really essentially arbitrary cutoff points based on historical data. So you take your historical data, you decide what bins you want, if you will. We ended up using essentially just standard quintiles with an additional bin or bucket at the very highest level, just to really highlight the really high data. So, your bins would be like 0 to 20%, 20 to 40%, so on and so forth. And then you just calculate what the thresholds are that are corresponding to each of those bins based on site-specific historical data. And somewhat surprising, that worked really very well, even without much refinement. Obviously, using what are essentially quintiles is entirely arbitrary. And then, there's real questions about what is the best what is the best range of data to use to calculate those thresholds? Is it all historical data? Is it over some set period of time? Should that set period of time be the same for all sites? A lot of, I think, questions that I'm hoping that we'll start figuring out a little bit more. But even with just, the standard way we just started doing it, which is all historical data using more or less just quintiles, it works surprisingly well. I'll show you a heat map of that in just a moment, but on the map, the color corresponds to those concentration categorizations. So we categorized in those quintiles and then further categorized it into basically just a really simple 3-tier system. Low watches that sort of middle ground. It's not low, but it's also really not high. And then actually elevated. And you can see which bins correspond to which ones there. You can also make a heat map, as I was mentioning, of that. And you can see that here, this actually shows and colors all 6 of those bins. You can see the color legend right there. This is what the data would actually look like because we're sampling twice per week. A little bit harder to look at. Something like this is a lot easier. This is just filling it in based on any days that don't have a sample based on the data from the previous sample from that same site. And so you can see what I was saying, it works surprisingly well. This is the picture that we got, and it's very obvious what the course of the pandemic was at all the different sites, as well as kind of statewide. You get a very easily interpretable picture that works really well. I mean, you can see where the Delta wave was very clearly. You can see where the Omicron wave was really clearly. I hope that's that band, a relatively short band, but of that 95+% bin, which is why I put that in there, because that wasn't really coming out. And that's by far the highest data we've seen at all sites was during that period. So this is working surprisingly well. Still needs some refinement, still has plenty of room for refinement, but working, I think really quite well for us at this stage. You can also relatively easily do aggregations over a variety of geographies. This one just happens to be statewide, something that we do. In this case, the red line is the number of sites at the 40+% quintile, which basically in this case can be interpreted as the number of sites at least that middle watch level. So that level or higher. And then the orange and blue bar chart is the statewide daily case counts, just for comparison purposes there. So again, you can very easily see the course of the pandemic, and it can be used for sort of predictive purposes as well, and we've used it for that. For this one, it's more sensitive, certainly because it's using a lower threshold than the next one I'm going to show. So it's potentially more predictive at the very beginning of when things are just starting to increase. You're also more likely to get sort of false positives, if you will, because it is more sensitive. It's balance you have to make there. Similar to this is be the number of sites at least the elevated level, so at least that 60% bucket, that one or higher. So the red line is that in this case. And so you can see a little bit less predictive in some cases just because you're having a higher bar to say like, yeah, this is potentially an issue. But you can more easily see what is happening when things tend to be on the higher end overall compared to this. So they both have their uses and they're relatively easy to combine. This is easy to do when you're sort of categorizing levels in this sort of fashion. Lots of other ways of doing this sort of thing as well. This is one that we've settled on and it seems to be working fairly well for us so far. We do whole genome sequencing of all of our samples. You can see an example of this here. We have data going back to October of 2021 now. And you can see, major shifts, as we all know, happened over time. This is, of course, not what the data actually really looks like. This is a pretty drastic simplification. What it really looks like is that, which is probably my favorite chart ever. I love this thing. I try to put it in every presentation I ever have because it's just kind of crazy to look at. But that's a more accurate, if far less interpretable, view of what is happening there. There's a lot of different lineages, sublineages, and individual strains at any given site at any given time. Lots of stuff happening all the time. And you can see, major shifts going on. A couple other projects we have, I'll try to go fairly quickly here. We have this ongoing collaboration with my counterpart in the syndromic surveillance world in Utah, as well as our counterparts at the federal level in CDC, working on it's essentially integrating wastewater data with syndromic surveillance in a better way, and seeing what, especially analytical techniques, we can borrow from syndromic surveillance and apply to wastewater data, since they're, they've been well established for quite some time now. And we view them as really complementary data sources. They have a lot of the same advantages, but they're looking at two different aspects of whatever pathogen target you're interested in. It doesn't have to be a pathogen target, really. You could use the same thing for chemical target, illicit drugs, for example. In this particular example, excuse me, in this particular instance, syndromic surveillance as it is implemented in our state and really with the national system, the NSSP, that is National Syndromic Surveillance Program, is chief complaint and or discharge diagnosis. It depends on what specific target you're interested in, but that information from emergency departments specifically. And you can see just an example chart from combining wastewater data in green and syndromic surveillance data in blue there. And this is just applying the really just standard EWMA algorithm to both particular data sets to do some aberration detection. Another example of the same sort of data. This is all sort of very preliminary stuff. We're hoping to have some tools available for certainly myself to use, but everybody to use in the not super distant future. But this is the same thing, just doesn't have the emergency department data added to this. This is solely wastewater data, but longer time span, and you can see the various different alerts that have come up. And seems to be working fairly well so far. Some other projects that we have ongoing or are planned. We have a small project looking for carbapenem resistance genes within our wastewater samples. We are collaborating with the Healthcare Associated Infections, or HAI program within our DHHS to try to link those wastewater results with individual samples from long-term care facility residents. So this will of course involve sequencing as well. So you can see what specific gene they have and start relating them to each other. We also have a project ongoing looking for Candida auris pathogenic yeast, which is not so far yet, very much a yet, I fear, found in Utah, certainly not frequently, but it is found in other neighboring or nearby states. So we have obtained samples from both Nevada and California. The Nevada ones were especially illuminating because they were from the Las Vegas area when Las Vegas had a fairly major outbreak of Candida auris. And we have actually just a couple fairly recent publications on both culture-based surveillance as well as PCR-based surveillance, which I think, doing this sort of thing for this particular pathogen is going to be probably of fairly high interest for a number of states, an increasing number of states as time goes by. We have the very early stages of a small pilot to look for opioids in wastewater, just starting with a couple, 2 or 3 sites probably for method development. That's where we are right now, sort of method selection and development, trying to find a method that's going to work with our wastewater samples, the equipment we have in the lab, and the skills that the technicians have in the lab. And at this point, using just an existing opioid panel that's available at Utah Public Health Laboratory, UPHL. And we also have some very strong plans to expand more broadly into additional non-SARS-CoV-2 targets in the coming year or so. Working on some initial target selection. As I mentioned, we're switching to ddPCR like now, and we were waiting for that before we did a lot of this because, of course, you don't want to do all of the work of method selection and development and validation for a system you're going to stop using. But there's a lot of options in addition to the things I've already mentioned. So influenza is sort of an obvious potential choice. RSV, hepatitis A, measles, Candida auris, as I talked about already. Lots more options within that realm. These are just the first 5 that came off the top of my head. As an interim step, as we were waiting for our new digital system to arrive, but we still wanted to get started in this area, we started using this commercially available viral surveillance sequencing panel. So it's a viral surveillance panel, has 66 targets on there. Really call it 65 because poliovirus is on there, but the poliovirus is extremely complicated surveillance-wise from a containment and programmatic standpoint. So we're currently disabled that particular surveillance channel. And it's intended for sequencing. So it's semi-quantitative at best, but we're starting to get some interesting results. You can see a very quick example right there. Unsurprisingly, a fair bit of GI-related illness or pathogens. Really not surprising whatsoever. And then a fair polyomavirus, which is a fairly common thing to see as well. You can see the big line through HCOV, OC43 is a human coronavirus, and it is what we are currently using as a process control. So we spike it into our samples. So we we'll better see it all there. But we spike it in at really high concentrations, and we have some concerns that it may be using up a problematic amount of the sequencing reagents. So we're in the process of moving away from that control. But so the line's in there because, yeah, we find OC43 everywhere because we put it into every sample. So of course we are. And that is it. Happy to answer any questions. Thank you so much.
Thank you for that very interesting talk. So there's a couple of questions in the Q&A and then also some from the other panelists. So one question is about if you're looking, I think this is related to the new panel. If you're looking for possible interference with vaccine shedding when considering those new targets, such as measles or influenza, or if any of the other live attenuated viruses and pathogens.
It would certainly be something to have some really serious thought and put some work into digging out what, if anything, can be found in the literature in those regards. We're currently not doing anything yet because we're just not doing those assays for any targets that would be relevant for just yet. But that is an excellent point to bring up, because that will be a potential pretty big concern for a lot of different things, like the things that you've mentioned. And off the top of my head, I don't know if there is significant GI shedding from vaccination with the attenuated versions of these, but there certainly could be. And if so, that complicates the interpretation of data you're generating. Absolutely. Excellent point.
And then there was a question about, so you have a lot of wastewater data that is very, very clear. So is that data being used in public health decision-making, or is it primarily used for surveillance? Like, what is the ultimate goal of a lot of these surveillance sites?
I would say yes, in total. So it is used for public health decision-making. The primary use for quite some time was in helping to determine the sort of prioritized allocation of limited individual testing resources. Now, that's not so much of a thing anymore. There's really hardly any state-sponsored testing left. But for a couple of years, there was a lot of state-sponsored testing, but not nearly enough to meet the full demand everywhere. And so you have to prioritize in some fashion. And we, I think, relatively early on realized that wastewater surveillance data was going to be a useful tool in that regard. So we developed a sort of composite metric using wastewater data and a bunch of other stuff, combined it together into a single numeric value that was a little bit easier to interpret, to help us figure out, okay, given that we have 6 this week, so 6 mobile testing teams that we can send out, where should we send them? Because we have 24 places we'd like to send them. So it was really useful in that regard. As I said, that's not so much of a thing anymore. So I think, going forward though, it will be one of the main uses, probably not the only use by any stretch, but one of the main uses for wastewater surveillance data I can picture is somewhat analogous to that, where it's going to be very useful as a way to determine potentially less where, although that will be an aspect, but certainly when, spending the time, money, resources, et cetera, on a more robust sort of traditional, if you will, response to something is warranted. Because you actually have data to base it on. You don't have to wait for, data to come back in from hospitals or for clinics or what have you. You're going to get it from, broader community level surveillance. So, and hopefully other people will think of really awesome uses that I can borrow.
Yeah, that's a big question moving forward, obviously.
Yep.
And then I had a question about, so you mentioned that you had to drop a lot of your sampling sites. So there's a big push right now to think about like equity of who is actually included in all of these sampling sites. So do you know which populations were more likely to be dropped by those sampling sites? And then if it would have been possible to maybe switch to like a once a week sampling to try and ensure that you get good coverage. And then a follow-up with that was, because all the sites were so similar, like, do you need as much coverage as you have? So thinking more about the sampling and the populations that are included. And I think that's probably our last question as well. Yeah.
Before I touch on that one, real briefly, somebody did ask about which company for that viral surveillance panel. It's Illumina. It's just a commercial panel. It's available. You buy it. We bought it. That's all. So getting back to the populations, yeah, I mean, the clearest divide in terms of who we adopt was rural versus more urban. We still have a number of rural sites, but the majority of sites that we ended up stopping sampling at were rural. So all the things that go with that as well, access to healthcare, willingness, and ability to access healthcare, and income, education, all the different socioeconomic factors that are associated with that sort of rural urban aspect. In terms of being able to, change sampling frequency, yeah, that's something we've certainly thought about. Most of the sites that we have sort of recontacted have still told us they just couldn't do it. It was a push even at the height of the pandemic, when it was clear, like, yeah, we'll do our public service as they saw it, and give this sample. And it's been tough to convince them thus far to kind of come back into the fold, but we're going to keep trying.
I think that's all the time we have for questions for Nathan. If there are any remaining questions, feel free to put them in the Q&A, and he can either address them. And I'm confident that he is probably fine with an email, as his email is on the slide. Then I guess we'll hand it over to Rebecca. Thank you, Nathan.
All right, great. Thank you for that. I will share. All right. Okay, so hi, I'm Rebecca Schneider. I'm a staff analyst here at the Houston Health Department, and I'm speaking on behalf of Dr. Lauren Hopkins. She runs the wastewater program here, but she was not able to be here today. But I joined the wastewater program in December 2020, so I have been with it as a staff analyst for a while. If I go to the next slide. Okay, so I want to shout out first our team. It's a really collaborative program. As you saw in Utah, we've got Houston Public Works, which is our utilities. We're all Houston, so we're all under one utility. It's Houston Public Works, the Houston Health Department, and Rice University. And our team's led under the 3 PIs, Dr. Lauren Stadler at Rice, Dr. Kathy Enser at Rice, and then Dr. Lauren Hopkins, who's at the Health Department and Rice. And folks are color-coded based on their associated institution. And it's a very collaborative program, and we always want to acknowledge everyone who helped out in the beginning and in the background, from the engineers at Houston Public Works, the Health Department, Rice University, and the researchers at the Taylor Lab at Baylor College of Medicine. So to get an overview of our program, we have this timeline that has wastewater milestones at the top and sort of COVID pandemic milestones at the bottom in blue. And we began wastewater sampling in May 2020. And then I have that as a date range as May to July, because started sampling in May with a bunch of people in the rooms at the wastewater treatment plant lab with a bunch of bottles of wastewater. And then by July 2020, early July 2020, that's when everyone decided there was reliable wastewater data. And so that covers that time period of figuring it all out. And at the time, we also added manhole facility level sampling, and then school sampling when I joined in December 2020, and have since added influenza starting at the school manhole level, influenza A and B, and then just this past school year have added RSV to not only the manhole sampling, but expanding it at the wastewater treatment plant level and all manhole samplings. And I'm going to try today to focus sort of on the latter half of our timeline, but to still give an overview of the Houston program. So in establishing a COVID-19 wastewater surveillance in Houston, it really relies on the collaborative partners, as I mentioned, and also high quality data. It was getting that high quality wastewater data, but also PCR case data. There was a big push That's sort of what I was doing before December 2020 at the health department, was making sure we were getting all reported cases sent to the health department, and getting folks online to be able to like electronically send PCR case data, and then timely making sure this was all happening in a way where we could then use the wastewater data for public health initiatives. And in Houston, we've got 39 wastewater treatment plants, and we sample at all 39, and they range from 600 people to 500,000 people. And it covers the whole city. Luckily, we don't have septics, and it's about 2.1 million people. And then on the manhole side, there are map shows the point locations for all the 75 manholes, and then the initial 63 lift stations, and sort of like you saw, we scaled that back, and we're now at 14 lift stations. So each week, we sample all those different locations once a week, and it's what our internal, both health department, public works, and lab capacity can handle. And it's all of the samples are 24-hour composite samples. They're influent samples at the wastewater treatment plant level. And then we continue to send them to 2 separate labs. In the beginning, it was Baylor College of Medicine, the Taylor lab, and the Stadler lab at Rice. And we have been able to bring on our health department lab. And so the samples are sent each week to both the health department lab and the Rice lab. Rice lab has been doing ddPCR from the beginning, and health department is transitioning, hopefully also right now. And that is then sent to me. This is the portion I fit in for the models and creating the reports, and sent out to the health department. And here's where we are as of our latest data. Like I said, we get it each week. So actually on Monday, when the 24-hour composite samples at the wastewater treatment plant level are taken, it's then sent to me on Friday, so later today for me. And we still continue to see a strong correlation between the wastewater levels. We do viral load as log 10 copies per day. So flow normalized, but not population normalized. And that correlates to under in blue, the PCR positivity rate, moving average. And then below that plot, we've got each 39 wastewater treatment plant. As a time series, we do spline estimations of our copies per day, log 10 copies per day. And also, as you can see in the heat maps, like across the city, you have very similar trends. The bottom one shows sort of the change in the week, the levels in the week prior, and the top one shows our like levels, which is we compare the current viral load to a benchmark level, kind of unique in Houston, but it does seem to work for us. And then all this continues, all the reports shown go internally, but they also go in different fashions on our wastewater treatment plant dashboard, or a wastewater surveillance dashboard, because it also includes schools. And if you're extremely familiar with our dashboard, you might notice this is a new look, and we have put some time into updating our dashboard as we see it to be a sustainable way for the city to show the wastewater data, especially as we expand locations like for schools and expand targets like adding influenza and RSV. And I wanted to highlight some of the stuff that we're doing on the public health level currently. There was a lot of work, initially with vaccination clinics and even testing sites. But currently we are looking at the percent of population in a wastewater treatment plant with an increasing trend. So for Houston, like let's say 8 wastewater treatment plants increasing, it's about 20% of our sites. But at a population level, if you took the 8 smallest, that's 0.7% of the Houston population. And if you took the 8 largest, that's 73% of the population. So look at it at a population level. And then based on at the time, 3 prior waves, we created these thresholds for a low, medium, and high concern for looking at specifically for ramping up, like our levels ramping up. And this fits into a larger scale highlighted here with what's happening for other surveillance metrics like e.g. ICU bed use, school outbreaks. And on the right, looking at that kind of as a heat map over time, the first wave is cut off and is cut off in the beginning. So you can't see the beginning of this wave, but we see in around November 2020 of last year, we start to get the beginning of the next wave. And we see wastewater is still a pretty early indicator for high concerns before the other metrics. And these are put in with the as a time series. So wastewater is overlaid, tried to color code it on the side. It's this magenta color. It's the copies per day. And that's overlaid with the positivity rate and AD visits and such. And at the bottom in black is our testing count. And as I'm sure everyone is experiencing, is our testing count is extremely low and is even below this 20th percentile threshold that we've made for ourselves. So we've at least still got wastewater as an indicator as testing goes down. And then briefly touch on our work beyond COVID, SARS-CoV-2. Like I mentioned, we've added influenza and RSV, and we've now been able to do that at all sites. And so here is influenza and RSV at the manhole sites for congregate living. They're separated by type. So we've got the jail locations, nursing homes, and shelters. And then followed up with at the school level, looking at simply for the manholes, we do not do any sort of flow normalization or time series. It's just, is it positive, inconclusive, or negative non-detect? And I can see a peak in the schools during the flu and RSV season. And as we add these additional targets, we're looking at them at the target level. For example, there is an internal influenza report that goes around for specifically for schools. And so our school wastewater monitoring heat map certainly goes in that report. And also, as of now, we've added back in influenza B, but influenza B had no detections in our initial last school year. And for lab capacity, we couldn't add RSV and have influenza B, so RSV took its spot, so to speak. But now, as of like last week, we will be able to have all three in our reporting. But then we split it up also at the school level and looking at what's happening at a single school for the three different targets and splitting them up by what part of town and specifically wastewater treatment plant they're in. And then at the wastewater treatment plant level, this was launched this late August, early September 2020, and we aren't smoothing these, we aren't estimating them. So we are just showing the log 10 copies per day for the wastewater treatment plants, the 8 largest wastewater treatment plants, that's where we piloted them, and then adding them up into a citywide total. And this was as of January. Now we have about mostly non-detects as flu season has gone away, but this report goes along with our internal report that looks at syndromics and surveillance for the different targets, or for influenza A and RSV. And then even beyond what we're currently looking at, we are thinking about also all the different things, all the different potential targets that exist. This is certainly outside of my expertise, but we do think about what pathogens, but also where are we looking at them? Do we want to look at the wastewater treatment plant level to then get a citywide level, or do we want to look at the manhole facility level? So we brought this in October to a wastewater advisory committee that we created with Dr. Ed Septimus and Dr. David Purse. Have selected these infectious disease doctors from the Houston area. And this committee was tasked with analyzing the results from a target pathogen prioritization survey. It went out to these folks as well as 2 others, and they came together to analyze the results and develop this prioritization table for pathogens, starting with priority order and then where, citywide level, at the facility level for specifically schools or nursing homes, long-term care facilities. It would be great to then send this survey out at the national level. This is maybe more Houston specific. Maybe we're more concerned with West Nile and Zika down here. But if you're more of a visual learner, we've got it as a Venn diagram. But the Rice Lab is piloting in different stages of piloting some different targets based on this list, and also lists that are coming out. CDC has a prioritization list or a suggested pathogen list, and the lab has focused on these 3, and there are different stages. I know norovirus is in a development phase, while CRS is in more of a validating phase, and then the anaerobic resistant genes are in a piloting phase. And like I mentioned earlier with the SARS-CoV-2 wastewater surveillance, it's collaboration and high quality data and timeliness, and we just are keeping this in mind as we get close to finishing developing these and what that will look like for additional targets. And then put out our resources, our lovely website and dashboard. And if you have any questions.
All right, thanks a lot, Rebecca. This is great, impressive work, and I think a very unique location, right? You have the ability of look at essentially the entire population and have no septic systems and the ability to, essentially get just about everyone's signal, and having done it for such a long time. So impressive work. We have a few questions. I encourage everyone to add on to what we have right now. Maybe let's begin with the interesting work on schools. I think there's a huge amount of interest, and also I think it can become quite political with schools very quickly, right? And so one of the questions here, what's the feedback from school programs and administrators? Have they used the data? Do they prefer to know? Also, a very interesting question that comes up often. What's the experience?
So I joined the program right after all the schools were selected and manhole auto samplers were placed, but there was a very long process, not only in what schools have viable manholes for just the facility level, but also what schools are allowing us to come on campus. So that work has to be done in the beginning and getting schools on board. And I think it helps from us to have a top-down where there was support from higher up in the school district to then support the person running the school and saying yes. But they have they enjoyed having the data? I'm not sure. I think that I have heard is school by school. They are having a sample, but some schools are excited to have it and implement it, maybe at the nurse level. We did a program in educating nurses that we are sampling, and there are public results on their wastewater, and some schools have taken it more to heart than others.
Great, thank you. Another question here is, thank you, great presentation. Do your labs process wastewater samples from sites in parallel, or do they handle different sites? How have you harmonized data from different labs and methods?
Oh, yes, it is in parallel. So every lab is doing every site, the same sites. And so we have, it's not included in this presentation, but there is a work on interlab. We have a linear regression in place, a cubic regression in place actually for bringing the labs up to the same levels.
Thank you. Just to clarify, I think the concern is that if the same lab always runs samples from the same site, it might not be evident that there could be bias. And so the question is, do samples cross, do you have samples that are analyzed by 2 labs, and then you can actually compare what the results are?
Yes, each, especially at the wastewater treatment plant level, each site is handled by each lab. So
Okay.
Yeah. So
Great.
so sometimes there is interlab variability between our
Yeah.
results.
Great. So we have a little bit of time. So for those who listen in, please, put in more questions while we are waiting for yours. Here's another one. One of the reasons that we use WBE, or that it has been advertised as being a useful additional tool rather than just one more thing to get the same result, is that you have early warning capacity. You have a lot of data, and what is your impression? I mean, you can even call back the trace lines that you had for clinical cases, and what's your impression from looking at the data? Do you feel you have early warning capacity from wastewater, and if so, to what degree?
That is a very great question, as we're entering like what, year 3 of all of this. Is that in Omicron, it was certainly extremely important, and we were mid-pandemic sending out data that even like local hospital systems were using wastewater as the leading indicator for, do they need to staff up because there's going to be staff shortages because nurses are going to be out, or so I'm trying to go back to that slide. Or do we need to reduce elective surgeries? And looking at it now, hospitalizations aren't, and like hospital bed use isn't peaking as high as other indicators. Wastewater and positivity rate are still peaking very high, but we're not seeing quite those scary peaks in the other indicators related to hospitalizations. So it's a question, is it leading? Certainly in the beginning of the pandemic. Is it a concern for hospitals now? That's a really good question.
Yeah. I don't know. I mean, just a quick, look at the plots. Looks like they have almost perfectly traced, which is fascinating, right? But it also, they're not shifted particularly. So, but of course, I mean, you have a very compressed timeline, so I'm not sure whether it's clear.
Yeah.
Let's move to a question from Ellie here. She asks, do you think the medical doctors are the only group that should decide prioritization? Is there a role for the public or other stakeholders?
That is a very good question. And that is where I leave it to our leaders of this program to weigh in and possibly say, yes, there should be more weigh-in from the people deciding what should be prioritized. And then there's the follow-up question is, can it be monitored in wastewater? Like, is it shed? Like, maybe we want to prioritize something as an infectious disease doctor and the public, but can it be monitored?
Yeah, I think the question maybe might come from your interesting idea of creating an advisory committee. And maybe you can comment on the composition of the advisory committee. Are these all medical folks, or are there, community spokespeople in there so that we get voices from the public as well and hear concerns?
I unfortunately don't exactly know this, but I did realize recently that they are all technically MDs. I do not believe they are all currently in MD doctor positions. For example, Dr. Minter is the director of the Fort Bend County, that's a local county's Health and Human Services. And so that would be someone who is on the public health side like us.
Mm-hmm. So first of all, I think it's important to just give you credit for creating an advisory committee rather than unilaterally decide what data mean. But of course, if you do such thing, then you open yourself to criticism because the composition of the board then has an impact of what the voices are and what the actions are. So it is quite complicated. Do you like to comment maybe on the fact that all the data were always carried to the medical community? And then it was the medically trained people who looked at the wastewater data and made decisions of whether that's useful or not. And they obviously weren't used to it and oftentimes didn't understand what the limitations and benefits of it are. How was your interaction with the medical community during the outbreak?
Ours was through Dr. Peirce, who is listed here, who is the chief medical officer for the city. So from the health department side, it was from the very beginning had, like February 2020, had weekly calls with local medical leaders in the hospitals and counties as one of his multiple calls for broadcasting a range of COVID data. So when wastewater came on, he brought in the wastewater to his weekly discussions. And so there was an education on wastewater data from the very beginning with that community. And I think that is extremely important. Yeah.
So again, kudos for creating a board member, and any lessons learned, please share them with the community, because this is very, it's tricky.
I think that is the idea of this next step. Like, great, we've asked these 10 people to look at the survey, but like, who do you ask next? And that answer has not been, that question has not been answered.
All right, maybe a less controversial question from Monica Trujillo. Do you see wastewater surveillance as a tool to detect new or re-emerging threats? You mentioned a little bit of that, and then she also asked whether you could see the use of shotgun sequencing, maybe looking for non-targeted surveillance of health threats.
Oh, those are good questions that I do wish Dr. Lauren Hopkins was giving this talk for. They have much more knowledge on the idea of new and emerging threats, especially Dr. Stadler. She's the one who does the wastewater side, in the sense that her thoughts on new and emerging threats, there's so much that you're getting. This is my interpretation from her. There's so much in a wastewater sample, just like so much in there, that how do you identify all of it? But that's where her scientific expertise could take off in answering that question. Unfortunately, I couldn't. And then for shotgun sequencing, and that's the idea that you just take a quick look, or you take one look at one sample. Well, what's the idea behind shotgun sequencing?
Different applications. It was specific here to the use of shotgun versus other sequencing and targeted methods. Yeah, I mean, if you're not the right person to answer that, that's perfectly fine. But I think your slides already suggested that you feel that there is value in wastewater monitoring, and you look beyond COVID, right? And you had a number of targets that you're already doing. Maybe you want to rattle those off again.
Yes. So influenza and A and B now, and RSV, but also these highlighted here. And norovirus, there are two listed more specifically for the norovirus, but these are the ones that we're looking at for potential. And I think Nathan did a much probably more scientific look at that. There's a lot involved in the lab part of it. I benefit from the lab doing all of it and giving me this lovely data, wastewater data, but there's a lot of work involved in their side for sure.
Great. Thanks, Rebecca. I think our time's up. If there's any remaining questions or highly specific ones that Rebecca can answer here, feel free to email them either to us or to Rebecca directly. There was information in the last slide. Back to Ali.
Thank you, everybody. Thank you so much to Rebecca and Nathan, and we'll see you all in May for our next webinar. Bye.
Thank you.
Thank you.